As Professor Clark has introduced me, I'm Abdul Seckam. I'm a PhD student at Cardiff Metropolitan University. My interest areas were basically medical microbiology and immunology, but when I got the opportunity to do a PhD, I wanted to challenge myself. And I said, you know what, you need to do something different. I was tired of looking at assay plates and looking at Pseudomonas aeruginosa and biofilms, and so I thought, well, I want to look at a patient's perspective, but I also want to look at the healthcare professional's perspective. So a lot of you have filled in my questionnaire in Harrogate, but this is another study that I'm going to talk about today, which is looking at the patient's perspective. So this is going to be the direction of my talk. But what I want you to do now is, I think we've had a plethora of amazing presentations. And if we look at Mary Rose's case, so I want you to think that of being the patient now. Forget about being the healthcare professional. Be the patient. Think that's your leg. For the women out there, there's going to be no Prada stilettos for a couple of months. You can't wear your sandals. Think of all the constructs and all the elements that the wonderful duo, the Upton duo, told us today about well-being. All those constructs, how does it affect all those constructs in well-being? How do you feel? How does it make you feel? The smell, the sight. You become socially isolated. But I want you to take it now to the next level. Imagine a wound care specialist comes to you and says, oh, I want to try this product out on your infected wound. What do you tell yourself? How do you feel? How's your wound feeling? If they put this product, is it going to work? Is it going to sting? Am I going to like it? How is it going to affect my life? What am I going to do with my children if I need to go? You know, you've got all these questions that need to be answered and that you're thinking about. So we do know that the patient's experiences are really examined, especially when you're looking at an antimicrobial being put on a wound. There's not enough literature out there to say, okay, so I've tried silver, but when the patient is using silver, how's that patient feeling? What does silver mean to that patient? So I decided I'm going to take into consideration the perspectives of the patient and taking into consideration of the perspectives of a wound type in the treatment and care I increasingly recognized as the focus for the organization of healthcare. And as Hawkins and Lindsay suggested, that understanding these experiences of patients living with leg wounds helps us and helps the wound care specialists know what the patient feels like, what they're going through, and it could help us for better endpoint results. So today, I think it was Wendy who pointed out that the international consensus that was presented came up with a document in 2012 and was presented in Yuma in Vienna on optimizing well-being in patients living with a wound. And patients play important roles in optimizing the power of those constructs of well-being, and in not only the physical, mental, social, spiritual, and cultural, but also their psychological healing. So currently, the outcomes and patient experiences at the heart of NHS reforms, and the initiative No Decision About Me is very important. I wanted to also say that there's been extensive literature not only with the optimizing of the patient's well-being, but optimizing the patient's journey by Olsey and Atkins in 2013, the wonderful workshops that you've all attended on the quality of life and well-being, Do We Know Our Patients by Anita, the Professor Upton and Dr. Upton, Wendy's wonderful lecture this morning, and also when we look at Mary Rose's experience in the workshop yesterday and her presentation now, I'm sure that it was very heart-wrenching, and you could feel that, because I can feel that. But you have to thank yourselves out here, because you guys are amazing, and without you guys, the patients, would not have that greater well-being and go out there and be positive beacons as a part of you. So this is what led me to my PhD study. I was looking at all this literature, and I said to myself, well, what am I going to do? I want to make a difference, and I want to take it a bit further. I want to look at a patient's perspective. But when I look at a patient's perspective, I want to look at antimicrobial in particular. As you may know that I'm a big lover of honey. I'm not saying that it works for everybody, but I thought, let me look at honey. When honey was placed on a wound, what did the patient feel? And what did it conjure up in their psychology? So an important psychological, the qualitative methodology is interpretative phenomenological analysis. I'm just going to abbreviate it to IPA because sometimes I get tongue twisted even saying it. And it's an important methodology used to explore the patient's lived experience. Earlier on today, Wendy did talk about the lived experience of patients in terms of their anger and in terms of their pain. But I'm looking at the lived experience of the patient applying medical-grade honey to their wound. So this sort of methodology offers the researcher a chance to engage with the research question at an idiographic level, so at a specific level, and look at a specific phenomena. The phenomena is using medical-grade honey on their wounds. So the key elements to the methodology is that it's an inductive approach, so it's a bottom-up approach. It does not test any hypotheses, and prior assumptions are avoided. That the participants or your patients are experts of their own experiences. So it offers the researcher the understanding and the thoughts and experiences and feelings. And the experts who are our patients are, they basically are the experts of the phenomena of using honey. So you could use any antimicrobial following this method. And also lastly, the researchers reduce the complexity of experimental data through rigorous and systematic analysis. This methodology has become very in vogue in the last decade, and I'm sure you've seen some of the references that Wendy has used earlier. Okay, so onto my study. So the aim is to capture and explore the meanings that the participants or the patients assign to their experience when using medical-grade honey to treat their wounds. Up to 10 participants are normally recommended. I've just interviewed 6 participants, and they all come from the Leg Club. So this is my way of giving back to you guys. The Leg Club has been amazing and very instrumental, and these patients were very willing to talk. So I'm going to give you a bit of insights into their transcripts just now. So my inclusion criteria, I use patients whose legs have been treated with honey and have shown successful or unsuccessful healing results. The exclusion criteria were patients who have not been treated with honey, not able to give informed consent, and anyone for whom communicating in English is too difficult. So ethical approval, I'm sure a lot of you have done IRAS and you know how difficult it can be, but I just have to tell you, I've scored because I did it in 3 months. Because somebody told me it took them a year. So I was granted ethical approval from the South West Wales Research Ethics on the 28th of May, and then the R&D approval on the 11th of July. So, okay. So collecting the data was through a semi-structured interview with a one-to-one interview. It was a semi-structured interview schedule based on Smith, and there were 3 sections to my questionnaire: the history of the wound and honey use, experiencing the treatment, and reflecting on the treatment. So, for instance, with the history of the wound and the honey use, I asked them questions such as, when and why was honey used? When did your wound start? And I used probes and prompts. The analysis is, I'm transcribing my interviews at the moment, and then I will be analyzing it line by line and looking for themes and seeing what converge and what diverge. So I just want to give you some preliminary findings at the moment. And I'm just looking at the section C, so reflecting on treatment. So the question I asked was, how did you view honey in the treatment of wounds? So there's 4 respondents. Respondent A said, well, this was a 60-year-old female with venous leg ulcers. The right leg healed with honey in 3 to 4 months, and the left leg is still being treated. She said, the honey appeared to be doing its job. You could see the wound heal week to week. I was more than grateful for it. Physically, it did its job. It healed the wound. Personally, I said, if it did the job, had eventually stopped the pain that I was in, that's good enough for me. That was great. And I think that's what the majority of people will tell you. if it does the job well enough and takes you out of a situation where you're in quite a lot of pain to a situation where you're not in pain and it's healed, then that's all you can ask of something. So honey worked for her, but I think when you look at that, you see this, she wanted some reassurance, and she was reassured that the honey was working. But for most of these patients, as you'll see, they didn't care so much about what antimicrobial you used. They just wanted it to heal. They just wanted something to heal. Respondent B was a 78-year-old male with a pressure ulcer for 30 years on his left leg. That's still healing, but he had a right leg ulcer as well, and that healed within a year of honey treatment. He said, well, it makes sense. Well, it makes you more well. How can I put it? Say that you know it's going to heal like that. What, like, well, before every time you took it off, it seemed to get worse, you know. Like, say with the honey, it took it that little bit. It worked for me. It worked for me. So he was saying that every time they tried a new antimicrobial, it didn't work for him. But every time they put the honey on and they took off, when he went to leg club every week, his wounds seemed to be getting smaller. So he was very grateful for the honey and that it worked for him. Respondent C was an 83-year-old female with a history of poor circulation and venous leg ulcers. She had treatment over 30 years with various conventional wound dressings. She said, I would welcome it because it is a natural substance and not chemically produced. So we ought to use our natural reserves of opportunities to use it. So I welcome the use of honey. I've never talked to anyone that has had a bad result from honey, but personally, I have put my faith in honey with anything else they have tried. She was well aware that this was medical grade honey, and that, you know, that it was manufactured by a drug company and impregnated into a wound dressing. So she was aware of that there. The next respondent was about 40 years old, was a male patient who fell and injured his left leg, was stitched and dressed. After 3 weeks, his wound became infected, and vac therapy and honey was used for 5 to 6 weeks and healed. He had another fall, and that led to an injury on the right leg, and doctors suggested that he should have a skin graft. However, honey was used to treat the wound, which healed in just over 6 months. He said, I mean, this is one of my favorite quotes. He says, it makes me feel comfortable that there is basically a natural substance to exploit its properties rather than, it's a natural substance, it's not a chemical. Okay, I know the honey is treated, etc. It's quite a nice feeling. I have never given it great thought, but it's quite reassuring. It's another life experience that I enjoyed, if you like. So I thought that was cute, but I've done another 2 participants that I'm going to tell you about where honey hasn't worked for them. The one patient that I interviewed, it was actually last week, she said to me, I used honey and I had a stinging drawing sensation. It hurt like hell. So I said to her, that stinging drawing sensation, what did that mean to you? Did it mean that the wound was getting better? And she said, no, I didn't even think that. I just wanted the stuff off me. So that was one patient. Another patient who was an 83-year-old lady, who I think is my favorite respondent. She started talking about Florence Nightingale and how Florence Nightingale used honey. So how her mother decided that she was going to pass down this information to her and how she was passing it down to her children. And then she told me, well, I tried honey and it didn't work. Doesn't mean that I don't like it, but it didn't work for me. I'm using silver now, and silver's working for her. So, I mean, what we can see in this year, overall from the themes, there's a theme of like the assurance, and there's also the natural versus the chemical. But what I wanted to say, not one antimicrobial offers a panacea. So honey may work for some, but may not work for others. And silver may work for some, but not for others. But if we don't have these patient stories and we don't understand what's working for some patients and not, we can't pass on this information. And I think stories like this are important so that when we are at our leg clubs and we do see these patients, we can always enlighten them with the stories of other patients to say that, yes, some antimicrobials may work, some may not, and are you willing to try it? These are the symptoms, and this is how somebody felt about a particular therapy. So with that in mind, I just want to say thank you so much for being so patient. I wanted to thank Ellie and the Leg Club. My supervisors, Dr. Mercer, Professor Cooper, and Dr. Thurloway, the Y Valley NHS Trust, the Leg Club in Ross-on-Wye, Janice Ryland, and also Claire Whitaker, who's in the audience as well, Dr. Uzi and Professor Hardin and Samantha Holloway. And those are the references I've used. So thank you so much. And have a safe journey home.